Hello everyone, this is Dr.Gulani. I'm an ophthalmologist and anterior segment surgeon from India, and today I have the pleasure to meet Dr. Gulani at Gulani Vision Institute. And it's been a long day, and finally we are ending the day. I have seen cases which are of all plethoras possible, and amazing unique cases which Dr. Gulani has the pleasure to treat and make them perfect. So we just thought that we would discuss about some of these cases which we came across today, so that we can spread a good message to young ophthalmologists out there, and you can take away a few learning points from whatever I have learned. Lovely to meet you, and it was amazing here. I had a wonderful time. Thank you so much for this. We can start by your technique of Painless PRK. Please tell us how you do that for all people out there.
Well, it's a pleasure. Absolutely. I love your enthusiasm and energy as you saw all the patients today who came here from practically all over the world. You saw them. Among the things you saw, you also saw the techniques when the way I do the master technique, right? The laser plastic, Painless PRK. Did any patient have pain?
No. Not at all.
And you even went on asking them day one post-surgery.
Absolutely.
So none of these patients we've seen had pain. It's now over 2 decades of performing this technique. And it's a wonderful technique, especially for eye surgeons, because you can increase the universality of the ability to perform refractive surgery.
Correct.
So you have no risk of Lasik, you have no pain of PRK, and you have no drama of smile.
Correct.
Think about it. Everybody can be a refractive surgeon. So that technique is something I love for you all to see and learn, and you've seen the outcomes. You can even do cases that are called not a candidate, thin cornea, dry eyes, extreme astigmatism. You saw 19 diopter astigmatism get corrected. You saw keratoconus patients having the technique. And how were they seeing?
Perfect. Yeah.
So I think the application is fantastic. The wide range will turn every eye surgeon into a refractive surgeon, which is what I love. And the ease of performing the technique, and the risk extremely low because they're not even cutting or chopping the cornea.
Correct. Even the pterygium cases, grade 3 plus pterygiums with a thick pterygium scar and all those things. But the outcomes which I saw today were amazing. And please tell us more about your approach to these cases.
So you saw the pterygium cases day one post-op, right? You saw the Irregular patient, the model from Colorado. You saw the other patient from California with the pterygium.
Luxembourg,
Then you saw the patient with the 3-time recurrence from New York, who had that thick recurrence with full adhesion, right? The point is my approach to all these cases doesn't change. So I, in fact, as I was talking to Dr. Nuj, even the pinguicula is difficult because that's an elective surgery in a perfectly normal eye, so you have to be perfect. And for over 3 decades, we are having these patients walk up to the mirror day one after surgery, and how do they look?
Perfect.
So even the level of difficulty doesn't matter. Every pterygium pinguicula case, you should look sparkling white next day and no pain. And how was their vision, doctor?
Absolutely perfect.
And we make them go up to the mirror, even I don't know what they will say. And that's my level of accountability, which I've shared in my textbook for everybody, right? Art of pterygium surgery. So using the no-stitch amniotic technique, we can make them look that good. It's the point is the good dissection and the armor plate technique that we discussed. And then you're seeing the results, how the patients are expressing.
Correct. And also for people out there, your approach, your structural and vision approach to every patient, how you plan the custom treatment for every patient. Like I saw an intact in one eye, and the other eye there was a PRK done, depending on how you categorize the particular pathology. So please a little bit about that.
So that was the Manchester patient from UK you saw, right? I did the corneoplastic makes differential intacts, I call it. Depth is different, ring size different, and then the way I do it is you saw the titration, what I did.
Yes.
While I'm doing it, the patient goes, wow, doctor, I can see, and I stop.
And sutureless.
No stitch always. And also you saw the reflex, how it became from very oval to circle. And I call that circle of size. So even while you're doing a structural surgery, let's say keratoconus, structural meaning you cannot make them see without glasses. Not contacts, I said, without glasses. So then they're structural. You got to do techniques to build the foundation. intact lamella cornea, all those stuff. Visual are those which can see with glasses, keratoconus patients. So those could be ICL, laser plastic, lens-based techniques, piggyback techniques, whatever, cataract-based techniques, all visual techniques. You can combine innumerable cases too. And then cross-link for permanization if needed. So you saw keratoconus patients today again from all over the planet. Yes, the Boston patient you saw who was actually cross-linked.
Correct.
And then sent to us, which I don't like. I like to correct first.
Yeah, first correct and then strengthen.
How was he seeing?
Perfect, very good.
And laser plastic doctors, so no inflammation, white eyes, no pain, pain again, right? Painless PRK.
Exactly.
So keratoconus also you saw a number of patients, all of them seeing. Then you saw complications of keratoconus, like the guy from Cleveland you saw, right? Day one post-op.
Yes.
So all keratoconus patients have the capacity to see. Don't just cross-link and leave them dependent on contacts or disabled transplants, correct?
Correct.
Right?
Especially, and also the RK cases. So many cuts of RKs, but neat entry, perfect incision, and clear cornea just on day one post-op with a very neat looking incision and no suture on it. So that was also pretty impressive and amazing to learn from you.
The concept there is important. All of you can do it. These were cases you saw. They were all 20 cuts and more. There was 28 cuts from California, San Francisco. You saw that patient. Then you saw the patient day one from Toronto, 31 cuts. Then you saw, and she had a lot of lamellar scraping of the scars, right?
Correct.
Then you saw Arizona. These three at least you saw day one post-op. You saw the 1 year follow-ups who came in with the 20 cuts and all. The 4 cut one you had seen with the scar too. So all of these you must enter without a stitch, because a stitch causes very high astigmatism in these cases. So enter without a stitch. That means your surgery has to be flawless. Still 4.5 minutes, but you don't move the phaco-tip, right? Phaco-tip remains in one place. You work with the second hand to make the whole surgery happen and come out. And how did they look today?
Perfect.
And they're all flying out. That's also important. The level of confidence in letting them fly so far away based on that.
Yes.
You saw the scar cases, the guy from, again, Canada, you saw the young guy. He had the Lasik, wrinkle. He had then had the topo-guided surgery, which I don't agree with. And then you saw me moving his central wrinkles of the flap
on
to the periphery. How was he seeing?
Perfect. On the table.
That's
good.
You saw the other guy, Miami. Remember Lasik scar guy again?
Yes.
We did yesterday. You saw his case too. So all of this is possible. And most important is to build up your techniques as Lego pieces. Be a flawless cataract surgeon. Besides doing it in 4 minutes, it should be flawless. Surgery looks like artistry. I don't believe in white, brown, black, blue cataracts. Cataracts are cataract. Treat it properly. But the ability to do it through a 30 cut RK, visualization of it, doing a perfect rexus, putting in a toric lens. You saw the patient from New Mexico where I put in the Aptera lens, the IC8.
Yes, IC8 lens.
Why I did that in her case was because the peripheral ectasia that was 15 diopters off the cornea.
So surpass that and create a tunnel of vision.
So the planning, then you saw the doctor who came with dry eyes we treated.
Yes, so the planning was really accurate and perfect, on point, so that we get these results. And one more thing I noticed here was the culture of the whole institute and how your patients are, their experience of the whole, the moment they enter and they exit, everything is well thought of. So that is also something which I really appreciate. It was mind-blowing.
Those are important things, Anuj. As you'll practice, all of your excellent surgeons.
Correct.
This is my way. I've decided to treat them like family. Today you saw, there were how many? 9 countries, 16 states. In one day you saw. All of them flew out. You saw them sharing their stories on a table around each other. And when they arrive, they're the only one patient in the lobby. Nobody waits. And yet 35, 40 of them leave next day post-op. We call it flyback Friday. So it is how you'll want to run the practice. I believe in this personal touch. You saw the patient who came in, the other new guy from New Mexico, we didn't operate on. We just saw him today. He came in with intense scarring, correct? How we went about looking for vision potential for him. And then the plan. And he's going to fly back for surgery. So you saw the patient from Jamaica, we had done the RefTech and refractive DSEC. So people are busy discussing DSEC, DMAC. Oh, that's okay. I want vision. So it has to be a refractive outcome of any surgery. So once you have that mindset of vision corrective technique, you will overcome the concept of just surgery.
Exactly.
Right? Everything you do then is affecting vision.
Yeah, true.
So if you do that, care for your patients, give them the love, attention, and it's not much work. It's something normal to do.
Exactly. After all, why are we ophthalmologists for this particular thing, right? So amazing. Thank you so much for everything. It was a pleasure. Pleasure.
My pleasure.
And
have you
now-
heard? Go and do amazing stuff. And do great work, guys. All of you. You have the talent. Just fight for your patients. Just stop doing routine stuff. Just rise. Don't do routine. Don't call things routine and difficult. That decides or takes away your focus.
Yes.
Every patient has the potential to see. Give them the best vision potential.
Yes.
Aim for beyond 20/20, no matter what the scenario. And keep it artistic. You saw least interventional, like we discussed, right?
Perfection in every bit possible.
Every bit.
Exactly.
Right?
Okay.
Pleasure again.